Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
Picture the scenario for a second. You are scrubbed in, right? You're standing there in the cath lab, and you are treating this post-thrombotic iliofemoral venous occlusion.
Oh, yeah. A very familiar situation for most of us.
Right. So you've successfully managed to cross the lesion with your wire, which is great. But then as you're evaluating the anatomy, an issue presents itself.
Let me guess, you need to go lower.
Exactly. To get adequate, healthy inflow to actually support a stent, you realize you need to extend your coverage below the inguinal ligament. And, the hesitation you feel right in that moment is completely expected.
It really is. I mean, standard dogma, which has been heavily reinforced by recommendations from the American College of Radiology. It basically dictates that stenting below the lesser trochanter is just a direct path to mechanical and clinical failure. We are taught very early on to respect that specific anatomic boundary.
Well, today, in this deep dive, we are analyzing the underlying evidence for that anatomic boundary, or perhaps the lack thereof.
Right, because we really need to look at what actually drives stent occlusion.
So we are reviewing two distinct data sets to figure that out. First, we have Mabud and colleagues' 20-year retrospective analysis from Stanford, which was published in the Journal of Vascular and Interventional Radiology back in 2020. And alongside that, we have the 3-year prospective VIVO IDE trial. That one was evaluating the Zilver Stent, published in the same journal in 2024.
So we've got some very recent data to dig into.
Yeah. The mission of our deep dive today is to really determine whether crossing the inguinal ligament inherently dooms a venous stent, or, if the field has essentially spent decades blaming geographic landmarks for what is fundamentally just a biologic and inflow-related problem.
I think that's the perfect way to frame it.
I think we should start by evaluating how these two cohorts were actually constructed.
Because you cannot simply place their outcome data side by side without understanding the foundation of each study.
Right. The designs of these trials dictate the clinical applications we can actually draw from them.
The Mabud paper provides this window into the messy, complex reality of a major referral center. We're looking at a cohort of 406 patients and over 1,000 stents placed over a 22-year period.
And because dedicated venous stents didn't even exist for the majority of that timeline, they were utilizing off-label arterial or biliary stents, right?
Yeah, precisely. Specifically, the cohort is composed of about 63% smart stents and 26% wall stents.
Mabud included complex multi-level disease. Nearly 38% of their patients required inferior vena cava stents.
That's a huge chunk.
And roughly 12% had an active malignancy at the time of the intervention. But most notably for our discussion on inflow, they had absolutely no inflow requirements.
None at all.
They even included patients presenting with acute deep vein thrombosis.
Which is, it's a critical variable to highlight here. Their own multivariate Cox regression analysis demonstrated that presenting with an acute DVT carried a hazard ratio of 3.65 for primary patency loss.
Wow, 3.65. So the Mabud cohort is just carrying this burden of high-risk physiology and complex lesion morphology.
It really is. But then you look at the VIVO IDE trial, which operates on the opposite end of the spectrum.
Yeah, VIVO gives us that highly controlled, highly selected trial data.
Very controlled. The trial enrolled 243 patients across 30 different sites, utilizing the dedicated Zilver Vena stent.
But the exclusion criteria are really what define that cohort.
Exactly. They systematically excluded IVC extensions. They excluded any lesions located below the lesser trochanter.
Right.
They excluded malignant obstruction. And perhaps most importantly for the patency outcomes we're going to talk about, they excluded any patient who had inflow or outflow obstruction greater than 20%.
Okay, wait. If we look closely at that structure, we run into a major analytical problem, don't we?
We definitely do.
Because VIVO actively excluded the exact high-risk clinical variables that Mabud explicitly included. Like, they selected out the poor inflow, the malignancies, and the IVC involvement.
Yep, they stripped all the really messy stuff out.
So if an operator tries to compare their success rates head-to-head, they are walking into a selection bias trap.
It creates a very dangerous illusion, honestly, if you only read the abstracts. The headline numbers present a narrative that isn't entirely accurate.
Because on paper, it looks like a massive leap forward.
Right. Mabud reports a 5-year Kaplan-Meier primary patency rate of 57.3%. VIVO, on the other hand, reports a 3-year ultrasound patency of 90.3%.
Which sounds incredible.
It does. If you take those figures at face value without interrogating the methodology, the naive conclusion is that the introduction of dedicated venous stents instantly doubled the success rate of these procedures.
But the clinical translation there is flawed because those two percentages are measuring totally different clinical endpoints.
Exactly. The definitions of patency in these two papers do not align at all. Mabud defines primary patency under really strict criteria.
Basically, any subsequent reintervention counts as a definitive failure, right?
Yes. If a patient returns to the lab for a routine venogram and the operator performs, say, a simple balloon angioplasty for asymptomatic instant restenosis,
Even if they didn't have symptoms.
even if asymptomatic, that patient is logged as a primary patency loss in the Mabud dataset.
Whereas VIVO approaches their headline metric differently, they rely on ultrasound patency.
Duplex ultrasound patency is simply assessing flow versus no flow. VIVO's chosen metric does not penalize the primary outcome if the stent required an intervention to remain open.
So if a patient in the VIVO cohort required a clinically driven reintervention, but the stent was successfully kept patent and showed flow on ultrasound at the 3-year mark.
They stay in the win column. That patient remains in the successful 90.3% cohort.
You know, we can actually reconcile these data sets if we look deeper into Mabud's summary statistics.
Yes, the assisted patency numbers.
Right. Mabud reports that secondary metric, assisted patency, which actually accounts for those intervening endovascular procedures required to maintain flow.
And that conceptually maps much closer to VIVO's flow versus no flow ultrasound metric.
Exactly. And when you look at Mabud's assisted patency at 5 years, it hits 90.3%.
Literally the same percentage.
It's crazy.
Yeah.
So comparing Mabud's primary patency directly to VIVO's ultrasound patency is basically equivalent to evaluating a vehicle by comparing its never needed a mechanic rate to its still drives rate.
That's a great analogy.
Right. The stents in the Mabud cohort aren't mechanically breaking down at a higher rate. It is the hostile biological environment of unselected, complex disease that forces the operator back into the lab to maintain the flow.
And that analogy holds up really well when you consider the mechanical data.
Yeah.
The structural integrity of these devices is the real, unqualified success story that's kind of buried in both of these data sets.
Yeah. Despite the differing methodologies, both studies agree that mechanical failure is essentially a solved problem.
It's amazing. Across a combined total of roughly 1,459 stents, spanning a 30-year gap in stent technology, there were 0 reported stent fractures in both cohorts combined.
0. That statistic is just remarkable when you consider the anatomy involved here.
It really is, especially since the Mabud cohort frequently pushed stents well below the inguinal ligament.
Which are highly mobile areas.
Very mobile.
Yeah.
And despite placing stents across these biomechanically stressful flexion points, they observed 0 fractures, 0 migrations, and 0 structural deformities.
Operators spend so much mental energy worrying about the biomechanical stress of the inguinal ligament, physically crushing a nitinol stent.
I hear it all the time.
But the data clearly shows that mechanical failure simply isn't the mechanism of occlusion.
Furthermore, both data sets provide clear temporal evidence regarding when these stents actually fail.
Yeah, if an occlusion is going to happen, it happens early.
The Kaplan-Meier curves for patency demonstrate this really distinct early drop and then a prolonged stabilization period.
Mabud's curves show the failure rate flattening out significantly after the 12 to 18-month mark, right?
Yes. And VIVO corroborated this by noting that the vast majority of their occlusions occurred within the first 12 months.
Okay, so the first year is the danger zone.
Definitely. In fact, when looking at the VIVO data between years 2 and 3, there were no new ultrasound-detected occlusions whatsoever.
So the clinical implication there is that if you can manage the initial biological response, like keep the stent open through that first year, the hardware stabilizes within the vessel and tends to remain patent long-term.
Which brings us back to the primary clinical dilemma we started with. If the hardware holds up without fracturing and the long-term patency stabilizes after a year, why does this intense fear of pushing a stent caudally persist in our practice patterns?
Well, we have to evaluate the below the inguinal ligament debate on its actual merits. And VIVO provides prospective subgroup data that directly answers what happens when you cross this landmark.
They do. The VIVO investigators pre-specified a categorization based on whether the Zilver Vena stent was deployed entirely above the inguinal ligament or if it extended below it.
And a good chunk went below, didn't they?
Yeah, in their treated cohort, 32.5% of the patients required stent placement below the inguinal ligament.
So when we evaluate the 30-day freedom from major adverse events in those two groups, the safety profiles are statistically identical.
Completely indistinguishable.
They reported a 96.2% safety rate below the ligament versus 96.9% above, yielding a p-value of 0.76. There is just no significant safety penalty for crossing the boundary.
And the patency data follows a similar trend. At 12 months, primary quantitative patency was 83.3% for the below ligament group versus 93.0% for the above ligament group.
Which sounds like a difference, but
With a p-value of 0.31, that difference does not reach statistical significance.
the data does introduce a confounder that requires careful interpretation here. The reintervention rate was not identical.
That is correct. When looking at clinically driven reintervention at the 3-year mark, freedom from reintervention was 86.3% in the below the ligament group compared to 95.5% in the suprainguinal group.
Okay, and that difference is statistically significant.
Yes, with a p-value of 0.03.
So a physician reviewing that specific p-value might just conclude that stenting below the ligament directly causes higher reintervention rates, and they'd say, see, this validates my historical hesitation.
But you cannot isolate that p-value from the baseline characteristics of the two groups. The authors reported the confounders present in that infrainguinal subgroup. The patients who required stents below the ligament did not have the same baseline disease severity as the patients who were stented above it.
Not even close.
Right. In the below ligament group, 90% of the patients presented with existing thrombotic disease. In the suprainguinal group, that number was only 57%.
And the physical morphology of the lesions was different too.
The mean lesion length for stents placed below the ligament was 15.6 centimeters.
Wow.
Yeah, which is more than double the 7.1 centimeter mean length. Furthermore, the patients requiring below ligament stents were 4 times more likely to have fully occlusive lesions, 45.3% compared to just 11.4%.
So blaming the inguinal ligament for the higher reintervention rate is just an error in causal attribution. The stent isn't failing because it crossed an arbitrary anatomical line on a fluoroscopy screen. It is failing because the necessity to cross that line is a direct marker that the patient suffers from multi-level, fully occlusive thrombotic disease.
Zip code of the stent isn't the problem, the underlying pathology is.
Well put. And the authors of the VIVO trial arrived at that exact conclusion. They state clearly that lesion morphology and disease severity, not the location of the stent relative to the inguinal ligament, were the primary contributing factors for failure.
And we also see this corroborated in broader registry data, which is reassuring.
Yeah, the recent EJVES 2024 registry data published by Jaleh on the anatomic classification of chronic venous obstruction really supports this biological model over the geographical one.
It does. If you review type 3 disease in that registry, which is defined as disease that crosses the inguinal ligament but fundamentally spares the inflow vessels, the 12-month patency rate remains strong at 80.8%.
So crossing the ligament doesn't tank the patency.
Right. The significant patency cliff, where outcomes drop severely, that occurs with type 4 disease. Type 4 drops to a 60.6% patency rate.
And the defining characteristic of type 4 disease is not crossing the ligament. It's the extension of the disease into the femoral or deep femoral vein, which obliterates the healthy inflow.
Precisely. So the primary takeaway for the operator is that securing healthy, unobstructed inflow is more critical to long-term patency than avoiding historical anatomical boundaries.
And once we accept that premise, the discussion shifts to the operational reality in the cath lab. Like, how do we properly size and manage these infrainguinal expansions when we are actively treating a patient?
Right. The Mabud paper offers a practical, empirical sizing convention that operators can adopt right away.
Yeah, I loved this part of the paper.
It's very useful. Their standard institutional approach utilized 20 to 24 millimeter stents in the IVC, stepping down to 12 to 16 millimeters in the common iliac vein, and 12 to 14 millimeters in the external iliac vein.
And when the disease required them to drop below the inguinal ligament, how did they adjust the sizing to accommodate that transition in vessel diameter?
They downsized to 10 to 12 millimeters for the infrainguinal segments. And the operational rule they utilized for any additional caudal stents was to size the stent identically to the patent inflow vessel, or at maximum just 2 millimeters larger.
And what about post-dilation?
For the post-dilation phase, they performed venoplasty strictly to the nominal diameter of the stent, or 2 millimeters less, to avoid unnecessary vessel trauma while ensuring adequate expansion.
So all of these sizing mechanics serve a single heuristic that operators should just memorize. The golden rule is normal vein to normal vein, securing at least 8 millimeters of healthy inflow.
That's the mantra.
We frequently discuss the lesser trochanter, but the data suggests it shouldn't be viewed as a hard stop.
No, it is simply permission. It's permission to continue extending the stent caudally until you reach a healthy, unobstructed venous segment capable of providing that 8 millimeter diameter inflow. You cannot compromise the stent by stopping in severely diseased vein merely to satisfy an outdated anatomical landmark.
Absolutely.
Now, moving past the procedure itself, we have to consider the post-operative management.
Right, because you land the stent in healthy tissue, you secure the 8 millimeter diameter of inflow, and the case concludes. But what is the optimal pharmacological regimen to protect that patency, especially when the stent has been pushed low into heavy thrombotic territory? It is important to have 1 to 2 months of enoxaparin, but what should you switch to after that?
The recent ARIVA trial provides the specific context we need for post-stent regimens in patients with post-thrombotic syndrome. The pharmacological takeaway is definitive here. A direct oral anticoagulant, such as rivaroxaban alone, is sufficient for maintaining patency.
It's funny because in clinical practice, many operators feel this instinctual pull to add aspirin to the DOAC regimen.
Yeah, assuming that complex multi-level stents just require aggressive dual therapy.
But the data strongly discourages that instinct. Adding aspirin to the DOAC provides zero additional patency benefit.
None. It does not improve the long-term flow rates.
What it does do, predictably, is significantly increase the rate of bleeding complications.
Because venous thrombosis mechanisms are fundamentally different from arterial thrombosis. They are driven more by the coagulation cascade and stasis than by platelet aggregation.
So you should only consider adding an antiplatelet to your DOAC regimen if there is a specific, compelling concern regarding poor inflow or highly compromised anatomical features, not as a routine default simply because the stent is long.
Exactly. Keep it simple unless the anatomy forces your hand.
Now, despite the robust nature of the data supporting caudal extension to secure inflow, there is a remaining gap in the literature that warrants consideration before we wrap up.
Yeah, this is the elephant in the room.
We are actively instructing operators to chase healthy vein, to cross the ligament, and to extend as low as the trochanter if the disease dictates it. But we have to address what happens to the deep femoral vein when we deploy a stent across its origin.
That is the necessary, honest counterweight to this entire interventional strategy.
Because both the Mabud retrospective and the VIVO prospective trial clearly demonstrate that the main stent trunk maintains excellent patency. However, neither study systematically measured or reported the branch vessel patency of the deep femoral vein after it was jailed by the stent struts.
We understand from the clinical experience of high-volume operators that patients rarely present with an acutely thrombosed profunda or greater saphenous vein post-procedure.
Right, but clinical observation is valuable. It is not a substitute for a quantified systematic duplex follow-up on those specific jailed side branches.
We just lack the hard data to definitively map that outcome.
So when we make the decision to jail the deep femoral vein in order to secure our main trunk inflow, we are making a physiological trade-off.
We're operating under the assumption that the venous collateral network will adequately adapt to the altered hemodynamics.
But the literature has not yet fully quantified the physiologic cost of that trade-off. We rely on heuristics to guide our hands, but venous biology doesn't conform perfectly to our procedural models.
It serves as a great reminder that while our understanding of inflow dynamics and our hardware have evolved tremendously, we still have blind spots regarding how these extensive interventions alter the wider hemodynamic environment of the leg.
Tomorrow, when treating iliofemoral venous obstruction, you might extend your stent all the way down but not inferior to the lesser trochanter to ensure landing in a normal vein of at least 8 millimeters, prioritizing healthy inflow over historical anatomic landmarks. That's all for today. Thanks for listening.
This is Dr. Rusty Hoffman, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.